the last videos, I have covered about the limiting structures and supporting structures of maxillary arch. Along with supporting and limiting areas, some areas which cannot take up masticatory loads should be relieved. These areas are relieved due to the presence of vital anatomical structures in that part of the denture foundation, or the bone and the soft tissues is not of that quality which can withstand the masticatory force. That means the soft tissue covering that area might be very thin. A relief area is that portion of the dental processes that is reduced to eliminate excessive pressure. Relief areas of maxillary arch are the incisive papilla, mid-palatine raphe, fovea palatina, torus palatinus, sharp spiny processes, opening of greater palatine foramen in severely resorbed ridges, bony protuberances on the alveolar ridge. Coming to incisive papilla. It is the elevation of soft tissue covering the foramen of the incisive or nasopalatine canal. This area is very sensitive and it should be relieved while making the impression. It lies near to the crest of the ridge as resorption progresses. Thus, the location of the incisive papilla gives us an indication as the amount of resorption that has been taken place in that arch. Incisive papilla acts as a guide for anterior-posterior positioning of the teeth. The labial surfaces of the central incisors are usually 8 to 10 mm in front of the papilla. Incisive papilla is used to locate the midline of the dental arch. The nasopalatine nerves and blood vessels pass through this foramen. Therefore, care should be taken that the denture base does not impinge on it, and it has to be relieved while making the impression. Mid-palatine raphe. Mid-palatine raphe is present in the middle of the two palatine bones, and it's a junction between the two, and this is a slight elevated bony ridge along the midline of the hard palate. Adequate relief should be provided in this area as submucosa is extremely thin in this area and mucosa is in contact with the underlying bone. It is a narrow cord-like band of tissue extending between the posterior nasal spine and aponeurosis of the tensor belli palatine muscle. According to Hartwell and Rand, this band of tissue is not meant to be compressed. Rather, it should receive slight amount of relief if it is prominent. Fovea palatine. Fovea palatine are indentations near the midline of the palate in the posterior region formed by the coalescence of several mucous membrane ducts. These are ductal openings into which the ducts of other palatal mucous glands drain. They are very prominent in some individuals, whereas in others it is barely visible or may be absent. The shape of these may be round, oval or oblong. Many clinical studies were conducted on the distance of vibrating line to the fovea palatine and the correlation of this fovea palatine position with the anatomy of soft palate. A clinical study conducted by Keng and Rao on edentulous patients to determine the distance of the vibrating line to the fovea palatina, the results indicated that the vibrating line is located 2.62 mm anterior to the fovea palatine. It was conducted in a mean of 160 subjects. There was a significant correlation between the distances of vibrating line to the fovea for different type of soft palate contours. Soft palate with deep slope or class 3 has a vibrating line at or just in front of the fovea. That means it has very less movable tissue in that area. While class 2 or the medium contour was 2.3 mm anterior to fovea, and class 1 flat contour of the soft palate, the vibrating line located approximately 4 mm anterior to the fovea palatina. For the class 1, you have got more area over there to get a post-dam effect, or you will get a proper seal in such kind of dentures. According to Boucher, a fovea palatini are close to vibrating line and always in soft tissues. This makes them an ideal guide for the location of posterior border of the denture. According to Winkler, fovea palatini should be used only as guidelines to the placement of posterior palatal seal. The dentist who observes the fovea and utilizes these landmarks as posterior extent of denture base can deprive his patients of several millimeters or up to a centimeter or more of tissue coverage depending on the palatal configurations. Sometimes the presence of thick ropey saliva may create hydrostatic pressure in the anterior part of the denture and thus affects the retention of maxillary complete denture. Torus palatinus. It is seen as a hard bony enlargement that occurs in the midline of the roof of mouth, seen in nearly 20% of the population. There are two types, mostly like almost entirely soft tissue, loose and flabby over it, and thin layer of mucous tissue covering the bone. Denture requires relief over this area to aid in retention and prevent soreness of underlying tissues. A smooth rounded small torus does not normally create much problem, as denture plate may be cut away to avoid tori or can be extended over it with proper relief. Whereas a large irregular lobed tori should be treated surgically, as cutting away the denture plate will significantly reduce the denture retention and also leads to excessive rich resorption.
Sharp spiny processes. Posterior palatine foramen has a sharp spiny edge that irritate the covering soft tissues. In individuals with excessive resorption of residual ridges, sharp spines can irritate soft tissue beneath the denture, which are normally covered deeply by the soft tissues. The knowledge about the underlying anatomical structures of the relief areas is very important during the final impression procedures, as the special tray should be relieved in proper areas. In the next videos, I will be discussing about the anatomical landmarks of mandibular arch under 3 broad headings, that is the limiting, supporting and the relief areas. Do subscribe.